Bill Ball asked a question on the Q&A, which I think we'll start off with. And I'm going to address this to Ted. The question is, I gather it's quite common for a patient with similar pressures in both eyes to have glaucoma damage in one eye much worse than the other. Any ideas why and what it might tell us about mechanisms? Are my left-hand eye mitochondria are likely to be different from those in my right eye, for example? Both eyes presumably get the same amount of vitamin B3. Ted, that's a very good question. Would you like to field it?
It's a great question. It's a sort of conundrum that we've been trying to address for over a very long time. I guess the first question is that even, I think Anthony sort of referred to this as a potential answer as well in answer to one of his own questions, is whether or not the pressure really is equal in the two eyes. There's a lot of measurement error, and there's a tendency for clinicians not to change the dial when they move from one eye to the other and just measure the same in the two eyes. And quite often there are in fact subtle differences. And we found that in the UK GTS, that in general, the eye, or in general, but quite emphatically, the eye with the higher pressure is the one that does less well. But there was a finding of a colleague at Moorfields, Sami Punasomi, from a long time ago now, which is that in normal tension glaucoma, the left eye very often is the one that develops glaucoma first. And why is that? And there was some speculation that it may be to do with blood flow to the eye and the way the major blood vessels come off the aorta, so that there may be a higher head of blood pressure going to the right eye than the left. That's possible. But even for other types of vision loss, so there are types of vision loss that arise from primary mitochondrial disease, and one eye will go before the other, even though we think that all the mitochondria are the same everywhere. So there may be other factors that trigger it in one eye with respect to the other, and we don't really know what those triggers are. And as to the question whether or not the mitochondria in one eye might be different from the other, well, that is possible. So all the results I was presenting were from peripheral blood test measurements of mitochondrial function, not measuring the function of mitochondria in the eye. And the mitochondria themselves may get damaged from high pressure in the eye and other factors. So it may well be the mitochondria in one eye are less healthy than the mitochondria in the other. Unfortunately, there's no non-invasive way at the moment of answering that question.
Thank you very much, Ted. That's great. Okay, so we have a question submitted in advance, which I'm going to address to Winnie. How have BAME patients, BAME of course is an acronym standing for Black and Asian Minority Ethnicities, fared regarding visual impairment and blindness compared to the rest of the population? So Winnie, perhaps you would give an explanation or some sort of perspective on that.
Yes, thank you. I mean, it's a very good question. And it can be viewed, I suppose, from a global point of view. So the highest prevalence of glaucoma in the world is in Africa. So it's about 4 times the prevalence in African Black patients than it is in Caucasians. And in certain parts of Africa, like Nigeria, 20% of those patients with glaucoma are blind. So the reasons for that are, for some reason, that there is a higher prevalence of the disease in people with West African inheritance, and they present clinically with higher pressures, more advanced glaucoma at a younger age. So if we go back to Anthony's discussion about advanced glaucoma, we know both in Africa, Caribbean, and Black and African and Caribbean populations in the UK and the States, that one of the risk factors for late presentation with glaucoma is being Black. So the reasons for this might be that, say in the UK, and we see this in our clinical practice, I mean at Moorfields, Ted and I will see a lot of Black African Caribbean patients presenting with quite advanced glaucoma. And reasons for this may be that they miss out on the testing because they're young, so they're under the age group that would normally be screened by optometrists, and they just by nature have had the disease for longer when it's picked up, so they're further along the line with advanced visual field loss. And there may be other reasons, such as reduced access to screening, such as optometrists. And we know that in areas of increased social deprivation, which is another risk factor for late presentation with glaucoma, there may be less access to optometrists for varying reasons. And there are other conditions. So, for example, in the UK, in patients with diabetic retinopathy, Black and South Asian patients are more likely to have visual impairment from diabetic retinopathy. And again, we don't fully understand the reasons around this, but it may be a higher rate of comorbidities such as diabetes and other medical conditions which maybe impact on people's ability to have visit their optometrist or come to the hospital. There may be certain groups who there may be a lack of awareness of glaucoma, so certain sectors of society where people don't speak English. And certainly I know that my colleague Ian Murdoch was targeting Asian populations in Ealing with culturally specific kind of glaucoma awareness programs, so that would be broadcast on specific radio stations, newsletters and things like that. So I think it's a very good question. In terms of whether we have much information on higher rates of visual impairment due to glaucoma in BAME communities in this country, I don't think we do, and it's something we should look at because we're very reliant on our site registration data, which is not always comprehensive, particularly in glaucoma. But I think to go back to the how can we improve outcomes, I think this ties into Tony's talk about whether patients presenting with advanced glaucoma should have a different management plan, such as early surgery. And that's something that we could be thinking with respect to certain high-risk groups.
Thank you very much, Winnie. We had a question actually about nicotinamide in advance, so sort of very prescient in view of Ted's talk. But there is a follow-up, and that was from one of our trustees, Chris Wall. I hope, Chris, that's been fully answered. But Alan Coddington has a follow-up. Are there other ways, apart from giving vitamin B3, of enhancing mitochondrial function in patients with advanced glaucoma? Ted, perhaps you might address that one.
The answer is yes. I mean, the number of pathways involved in good mitochondrial function is huge. So there are a number of points in the pathways that it might be possible to intervene. So one other medication that is being looked at, not in a clinical trial yet, but I think there's an intention to go for funding, is metformin, which is used in diabetics for type 2 diabetes often. That has a beneficial effect on mitochondrial function. There are other medications. So there's a company in Italy which produces an eye drop called citicoline that is very keen to start running a clinical trial. That has a multitude of potential effects on nerves and on the eye, one of which may be through the mitochondrial pathway. So the answer is yes, but we won't really know which ones are best until we've done some more clinical work. So for instance, giving people vitamin B3 or one of these other medicines and measuring the mitochondrial function before and after. So there's a lot more work to do to know which the best approach might be.
Ted, what do you do if one of your patients comes and says that they've been getting ginkgo biloba from Holland and Barrett? What's your advice to that?
Well, I usually say fine. It's most unlikely to do much harm unless the patient is about to go to surgery, because it's an anticoagulant. So I tell people to stop it before going to surgery. There's little scientific evidence that it's actually beneficial. but it probably does no harm. So I have no objection to my patients using it.
Okay. Tony, I'm going to address a question to you. Have there been any substantial improvements in outcomes for people with treated glaucoma in the last 10, 20 or 30 years?
So I guess it depends what you mean by outcomes. I think that we're better at measuring outcomes now. We have much more of an awareness of what outcomes are important to patients, rather than necessarily outcomes that were important to clinicians. We always used to traditionally measure things like pressure, visual field, so on and so forth. But now, as was demonstrated by tags and also in Gus's study, quality of life is the outcome which we tend to concentrate on. So in terms of outcomes, I suppose our measurement has changed. We are looking at a whole variety of new surgical interventions, which again, I suppose you could argue are different outcomes which we didn't have before because those procedures didn't exist. But in terms of, is there anything which has made a massive difference to outcomes, perhaps? I don't think there is really anything that has made a massive difference to outcomes. We just perhaps know how to manage patients better and prioritize things in a different way.
Thank you very much. Sue, I'll bring you in now. We've talked about different models of care. The pandemic has thrown us a lot of curveballs, and lots of new pathways are being enacted. Would you just say something about how you feel that primary eye care, that is optometric practices, and secondary healthcare can perhaps interact better, more effectively, with better outcomes for patients?
Yes, of course. As I'm sure we all know, ophthalmology service has been absolutely, dramatically affected by the pandemic. But primary care optometrists have largely remained open, actually, through most of last year, and they're still open now. So anybody who is concerned about their eyes in the first instance really is best placed to contact their optometrist. And a lot of advice can be done over the phone. When we had the first lockdown, then lots of optometrists were providing phone or video consultations. And actually often all that's required is some reassurance. And so if anybody's concerned, then in the first instance, they should contact their optometrist. But actually most optometrists now are offering routine appointments again now, because they have made their practices as COVID secure as they can, all PPE and appropriate screens and social distancing and so on. So actually, we're anticipating that actually a lot of the patients who might otherwise have gone to the hospital in the first instance will be going to their optometrists, whilst the hospitals are sort of more dealing with the COVID patients.
Thank you, Sue. Another question, I'd like to hear panelists' current view of PreserFlow Microshunt. In particular, under what circumstances would it be preferable to a trabeculectomy for primary open-angle glaucoma? I'd also like to know the answer to that question. No, I'm just joking. It's a very good question. The PreserFlow Microshunt was originally called the InFocus. It's undergone a lot of different names. It's now called the Microshunt. So I think I'll field this initially. It is an aqueous shunt of sorts. It's a tube that drains aqueous fluid from the eye. It's a tiny one, and one which goes in through a little scleral tunnel. It has a number of potential advantages over other aqueous shunts. The honest answer to this question is actually that the indications are emerging. No one absolutely has a list of criteria, but it is one of the more interesting and exciting devices in terms of its efficacy, and probably, we hope, also in terms of its safety. So in answer to the question, under what circumstances would it be preferred? A lot of people were putting these devices in during the time of COVID because it was thought to be a smaller procedure with perhaps less follow-up required. One of the advantages of all aqueous shunts is that it drains aqueous quite a long way back, and therefore what blebs form tend to form towards the back posteriorly, and so aren't necessarily subject to the same problems that blebs can cause when they're more anterior, more forward placed near the border of the cornea. And so the honest truth is that the new indications are emerging. It remains to be seen whether it's as effective as a trabeculectomy. It's probably the closest yet in terms of efficacy to trabeculectomy. It does appear to be a safe procedure, although any surgical procedure, of course, has the potential for some complications. It does require the use of mitomycin, the very powerful antimetabolite that we use routinely at the time of trabeculectomy, and some people use at the time of tube surgery. I think it might be useful to ask the other panelists. Winnie, would you like to share your views on the Microshunt?
Yeah, yes, as you say, it has advantages over the trabeculectomy. It's quite, in a way, it's quite a simple procedure to do compared to the trabeculectomy, and it has a lot less of the, I like to call high maintenance aspects of a trabeculectomy. I think as you start using a device like this more, and it is one of the more promising MIGs, you can see that probably needs to be selection of particular patients that are appropriate for it. And we have noticed at Moorfields that there are some patients who are getting quite low pressure, and that can happen in the first few weeks after the surgery. And it's not a problem for most patients, but there's some patients where low pressure is not good, and there can be complications due to that. And the reason for that low pressure is that you can't really control how much drainage is going through the shunt like we do with a tube or with a trabeculectomy. So I think as time goes on and we do more of these procedures, we'll fine tune really which patients it's more appropriate for.
Thanks. Ted and Tony, do you have views on the Microshunt?
Nothing to add really yet. I mean, there has been a clinical trial undertaken to compare the PreserFlow with trabeculectomy. So I'm really waiting to hear the outcome of that trial. And as you've already said, maybe some of the longer term data are on safety. So if the bleb morphology is better, then that would be a reason to go in that direction. So I'm really just waiting for some more data.
Okay, fine. So another question, and I'm going to address this to Tony, because I know, Tony, you have a keen interest in patient participation. Is it possible for all patients or users to have a personalized booklet of care? This might include annual assessment, or this must include annual assessment of future visual impairment described in meaningful patient-centered language.
Okay, so that's a very interesting suggestion. I think what the comment is alluding to, perhaps this being part of standard care for an individual, where a patient is issued with, I suppose, an ongoing log of information related to their glaucoma. That certainly doesn't exist at the moment. There are some efforts to achieve this, but they're usually dependent on the patient collecting the information themselves. I know that Pete Shah has developed this patient passport, which is a little booklet which patients can bring to clinic with them, and they obviously they collect the information that they want at the clinic appointment, and then enter it in the booklet, and it basically is also an opportunity for them to record things that they might want to discuss at the presentation, particularly in relation to drops or concerns that they have. But at the moment, there is no formal process by which we issue a booklet to patients, even though I can see that that would have many advantages associated with it.
Okay, thank you. So Winnie, this is the question you've been waiting for. A question submitted in advance. I've been reading about the Fyodorov restoration therapy and wonder what you think of using electrical stimulation to increase the functionality of retinal cells and improve the messaging system along the optic nerve to the brain. Can it, as it claims, prevent further visual loss and improve visual fields? So perhaps you'd say something about Fyodorov, and then perhaps, you know, it is true, I think, perhaps you'd say something more generically about new techniques that appear to be slightly out of left field, and those which make claims which are perhaps difficult to substantiate in terms of published literature. Yeah,
so the Fedorov technique is the use of electrical current stimulation. I think electrodes placed on the outside of the head to try and improve the connections, the electrical connections in the brain and the neurological system. And so I think it takes place in Germany. There is quite a few publications describing the impact of it, and there's one trial, and that's where we normally hone in on, where we're looking for evidence as to whether a new treatment is effective, and then we will critically appraise that study. The trial has taken patients with glaucoma and non-glaucomatous optic neuropathies, a very small group of patients, and subject them to this stimulation, which is quite intensive. It's 50 minutes a day for I think at least 10 days. They have shown in this trial, and they compared this with sham treatment, so maybe electrodes with no electrical current. They showed a slight improvement in the visual field, but this was short term. It lasted only a couple of months, and they showed no improvement in visual acuity in patients with reduced visual acuity, which would be more likely the non-glaucomatous group. So that's very limited information, and it sounds like quite intensive treatments, which I expect you have to pay for. So I would say at the moment you're not really getting value for money. It doesn't sound particularly harmful, but I think then to move on to the question about new treatments, I suppose I would say regeneration of the optic nerve and the connections between the optic nerve and the brain is really the holy grail of glaucoma management. If we could do that, then a lot of our problems would be solved. And I think if there was a truly effective novel treatment for that, we would know about it. And that would be based on, you've heard 2 excellent talks about the use of randomized controlled trials to test a treatment or an intervention, and to test it in an unbiased way, so that you can say without doubt at the end of that trial, this treatment made a difference or it didn't. And when you look through the literature or try and find that, for example, for this Fedorov treatment, I can't really find it. And so really, I would say to the people who are doing that treatment, perform a large randomized controlled trial and show everyone your workings of how you do it, and then consider it. But there'll be all sorts of other factors that come into it. Is it cost effective? Does it have harmful side effects? Do people have to pay for it, etc.? At the moment, I don't see any great benefit from it.
Thank you, Winnie. I'm going to go to the last of our pre-asked questions, and perhaps while I'm doing that, you could look at the open questions on the Q&A, because almost all of them have 2 thumbs up, and it will be helpful if any of you would like to know the answer to any of these questions in preference. If you click on the thumbs up, they'll go up, and we can try and answer the questions that drift to the top of the list first. So this is a question for Ted. Are there any new developments in what causes the damage to retinal nerve cells in open-angle glaucoma?
That's a very good question. I mean, so there are strands of evidence that come from various different directions. So one is genetic analyses. So looking at large populations and identifying differences between genes in a glaucoma population compared to a non-glaucoma population can give an indication of pathways that might be involved in the damage to the nerves in the eye. So I showed during my talk a publication by Anthony Kawaja, who looked at nearly 140,000 people and the genes that were responsible for raised pressure, and identified a number of pathways. So each of those gives both the clinical and laboratory scientists a direction to start looking in more detail for areas where interventions might work. There's a bit in the literature about the role of inflammation in damaging the nerve cells in the eye in glaucoma. So that's a potential, not actually especially new avenue, but one that's sort of coming up in prominence over recent years that might be a direction to look at. And then there are the things that I talked about, the new potential interventions People have looked at large populations to see whether or not medications that people take as a routine for other things might impact glaucoma. So there's a suggestion that SSRIs that are taken for depression might actually protect people from glaucoma, and some calcium channel agonists that are used for blood pressure management might be bad for glaucoma. So there are various strands of evidence coming from different directions, but probably nothing earth-shattering at the moment, which will produce a big step change.
Thank you, Ted. I'm going to go to the top of the list now. Mark Lambert asks, Tony referenced visual field loss, which may stop when the pressure reaches 10 or 12. Why is that when normal pressures, the range references between 10 and 21, or as Nice would now say, perhaps 24? Tony?
It's a good question. I think if you look at the pressures that we're referring to at the very lower end of the normal pressure spectrum, the 10 to 12, then what we're assuming is that you get no more pressure, you get no more visual field loss, which is related to the pressure being too high for that eye. And it would appear from the studies, not necessarily giving you a straight answer here, it would appear from the studies that if we achieve that pressure, then we don't tend to get very much, the likelihood of further visual field loss is greatly reduced. The mechanism, I don't have a straight answer to that. Maybe somebody else can help us with that. Looks like.
Go ahead.
Yeah, I was just going to add to that. I mean, I think it's a great answer. I was just going to add that not everybody needs a pressure of 10 to stop their glaucoma progressing, I think. The sort of message is that if you were to safely get everybody to 10, then you might stop everybody. But there are plenty of people out there with pressures of 18 who aren't getting worse and don't need a pressure of 10.
Yeah, I absolutely concur with that. That's true.
Thank you. Winnie, Andrew Cowser asks, how successful is SLT compared to surgery?
Good question. There is no trials that I'm aware of that are comparing the two. The two main trials on SLT are the LIGHT study, and there will be a study published from Tanzania looking at SLT versus eye drops. And the suggestion coming out, a lot of these treatments like SLT or eye drops are not including patients with advanced glaucoma. And so it's difficult to say how they will perform. But there is a suggestion that SLT doesn't perform quite so well as a primary treatment for patients with advanced glaucoma. And so surgery probably does better there. So anecdotally, that would be my experience, is that SLT works best as a first-line treatment for somebody who is newly diagnosed with glaucoma, with early to moderate glaucoma. It doesn't work so well if someone has been taking drops for many years, and we think that maybe the drops have somehow affected the trabecular meshwork, or there's just more damage in the trabecular meshwork. And so in patients who have more advanced glaucoma or have been on treatment for many years, trabeculectomy is likely to work better in terms of bringing the pressure down.
Thanks. I'm going to direct a question now to Sue. It's just because you have some perspective, I think, on this that maybe some of us hospital consultants maybe not. Every time I see a hospital eye clinic appointment, I see a different consultant. The consultants offer different treatments for and continue with drops or go for trab. How can patients make informed decisions in these circumstances? And as a lawyer as well, patient information and patient choice is I know is dear to your heart, and you know that is a different experience from people who have an optometrist, for example, that they develop a relationship with. Could you say anything about that perhaps us hospital doctors may be unaware of or do not have the same perspective on?
Well, I think it's a very good question, and I'd like to know the answer too. I think it goes back to one of the earlier questions actually about asking for a patient passport. I think it would be extremely useful if more information was shared between well, all the various sectors of the health service, because what also happens sometimes is patients come into their optometrist and they're asking what the hospital has told them. I'm sure the hospital did tell them, but there's an awful lot to take in at these appointments, and we don't know because we don't always get letters back from the hospital. So yeah, I think it's very difficult. But what you could do, you can phone up the Glaucoma UK advice line, which I'm sure most, if not all, of the audience are aware of. And if you're being recommended to have an operation, we also provide a buddy service, so people can speak to other people who have had that treatment done. So I think I would steer the question in that direction. But yeah, I think it's a very good question, and one of the disadvantages of the way the current health service works, possibly.
Yeah. Ted, go ahead.
Yeah, I mean, I think it's a really good question, and it's a real area where we as consultants could do a lot better. And the question I think that comes to mind is, how could we do better? And like so many things, a good electronic record would be a way of doing this sort of thing better, because what happens at the moment is that very often when a consultant sees a patient, they don't write in the notes what their opinion is, what the decisions are, and why they've made those decisions. So someone reading the notes at the next appointment don't know what's been said to the patient before, and may say something that sounds very, very different. So a good electronic record where we have a living management plan that's reasoned, I think would help everybody a great deal. I mean, it's a wish for the future, but I think we can do better.
I think there's also has to be an acknowledgement that actually sometimes some different treatments are not necessarily better than each other, and I think we have to tailor our recommendations according to what patients feel. We have our own idea about risk and benefit, but it's ultimately the patient who has to make that choice, and it behoves us to explain the options to them. And sometimes I say to people, if you ask 5 different glaucoma doctors the answer to your question, there may be 2 or 3 or different answers, and I think that that's an important consideration. But if care is shared and split between different consultants in the same hospital, it's very regrettable if those wide variations in practice are allowed to yo-yo someone's care. But what I would say is that broadly, units like ours do think along the same lines. I'm sure it's the same at Moorfields, but we broadly do the same things. We all should be following NICE guidance, EGS guidance, and broadly do. And there are questions to be answered like that, which Tony is about to give us the answer to. These are questions the profession wants to know, and I think the honest thing to do is to explain and acknowledge what we don't know as well as what we do know, and involve patients in every single decision wherever possible made about their care. Okay, so Lorraine Harper asks, what is recommended if pressures remain high after trabeculectomy? Tony, would you like to take that one?
Sure. So there are a variety of options available, really. Sometimes it's possible to kickstart the trabeculectomy operation again. If it's scarred down, we can undertake a procedure called a needling, where we try to scrape away the scar tissue which has formed to stop the trabeculectomy working very well. And we usually use some anti-scarring chemical at the time that we do this. And this can be quite successful in many patients in restoring function. We can simply add drops to the eye where the trabeculectomy isn't working very well, and this is often successful in reducing the pressure down to a satisfactory level. Should either of those two not work or not be successful, we can repeat the trabeculectomy, or we can carry out further surgical interventions such as an aqueous tube. So there are plenty of options available for patients whose trabeculectomy isn't working as well as we would like it.
Thanks, Tony. Our very own Rashenda asks, does anyone know what damage COVID can do to the eyes of COVID patients? Winnie?
No is the short answer. I mean, I know patients with COVID were getting conjunctivitis. I'm not aware of it causing intraocular problems, but we're still finding out a lot about COVID. So there is a higher rate of blood clotting episodes. Embolic events is what I mean to say. So theoretically, there could be higher rates of optic neuropathy or retinal vein occlusions, artery occlusions. But I think at this stage, I'm not aware of that, but it might be something that comes out in the future as we get more knowledge about the impacts of COVID.
Yeah, absolutely. A question about eye drops and generics. I take many eye drops, including dorzolamide. This is a question I'm reading. I'm not giving my lived experience. I have used more than one generic. My pharmacy will currently only provide one particular generic distributed via Aspire. The problem with this product is that the bottle orifice is so large that the drops come out without squeezing it, so my eye gets totally wetted, which is uncomfortable. Surely there should be a product standard for the bottles, not just the chemical. And that, you know, generics have been and are an area of concern for many of our members. Ted, what would you say to that?
Well, I recognise it as a problem to which there's no immediate solution, and I think it does require some lobbying on the behalf of patients by patient support organisations to the MHRA and regulators to try and get some regulation in place to consider the dispenser as well as what's inside the bottle. And I thought Glaucoma UK did have that on their list of things to advocate for. Maybe I'm wrong, but
no, you're right. Of course, it's not just the size of the hole. The plastics are of different stiffness, and some people, especially with arthritis and other hand problems, find it difficult to squeeze certain bottles. Some of the bottles of what appear to be identical products are given different storage requirements. Some have to be refrigerated until opening. Some have to be refrigerated constantly, and it is a source of great confusion. Of course, one of the great drivers for generics is cost, and we know that we may prescribe a proprietary medicine, and the people who pay for healthcare, CCGs and GPs, will substitute that with a generic. But it would be great if the generics were quite similar, but they are very different. Some 10 or 20 different bottles of latanoprost, for example, all of which have appear different. So we know that that's a common experience. Tony, the top rating question from our trustee Ray is about medical treatments against surgery. So would you just give a little perspective about medicines, drops, and as opposed to lasers, which I know Winnie's already talked about, and surgery, perhaps giving the range of surgical options, because we've talked predominantly about trabeculectomies, but I know there have been questions, and there's a lot of discussion about MIGS and other procedures. Can you give a bit of perspective about how we choose what we choose?
So traditionally, we have put patients on drops as our first line of treatment. Of course, the light study may change that going forward, but traditionally we have used drops. The introduction of the MIGS has brought another dimension into how we manage our patients. So often patients are undergoing cataract surgery, patients who have glaucoma are undergoing cataract surgery, and this presents us with a surgical opportunity to carry out something beyond the cataract operation, which may reduce that patient's need for drops. And often when that opportunity arises, we can insert one of these MIGS devices into the eye at the time of cataract surgery. And this can have several effects. One, it can reduce the need for drops altogether, or it can reduce the number of drops that patients require to control their pressure adequately. So it can be advantageous in either of those two ways. But often it's only a reduction rather than a release from having to use drops in the future. Many patients take the opportunity when we have this discussion with them in clinic because they don't like putting drops in, and who can blame them? So that's the future. That's how we manage drops in the context of modern surgery. If you need to go beyond MIGS, which generally only give a relatively low pressure reduction, then we can talk about the other surgical interventions apart from trabeculectomy, Pressiflow is probably the next one which we would consider, which almost mimics trabeculectomy in its effectiveness. At least that's what the literature is suggesting so far, and may in the future replace it in some patients. In patients who have failed the MIGS and the traditional surgery, then we have the option to put a glaucoma drainage device in, and the advantage of this is that we can put this into eyes where there's a lot of scarring, so they're no longer suitable for the traditional surgeries of TRAB or indeed Pressiflow. And these also give good long-term pressure control, but they're much bigger operations for patients. So we tend to retain those until our last line of intervention.
Thanks, Tony. A very good question here, which I'm going to address to Winnie. Does cataract surgery slow glaucoma progression? Winnie's got a keen interest in angle closure, and I'm sure we'll have a very good perspective on this issue.
Yeah, so if we look at primary open angle glaucoma, I think there is some evidence that cataract surgery may reduce the pressure, though I don't think there's a definite link between that and stopping progression of visual field loss. In angle closure glaucoma, it's very different because the lens is key to the mechanism of the closure of the angle. So we know that by removing the lens, we open the drainage angle up, and depending on which stage you do that, it's highly effective in reducing the intraocular pressure. So in patients who've got established angle closure disease with high pressure and early to moderate glaucoma, removing the lens or cataract is more likely to bring the pressure down than other interventions such as laser iridotomy. And that's purely a kind of mechanical reason. And it's very good news. This has been proven in the EAGLE trial. And it's very good news for angle closure because it means we can intervene with this surgery, which is generally effective and safe. And in some patients, we can then take them off their drops and possibly discharge them. So it has much more of an advantage in patients with angle closure than open angle glaucoma.
Thank you very much, Winnie. Ted, what about acupuncture for glaucoma, either in reducing IOP or improving mitochondrial function?
I'm not aware of any evidence of the effectiveness of acupuncture. Again, it's a bit like the ginkgo biloba question, which is I've got no objection to patients trying it. But Winnie has already referred to the best evidence coming from randomized controlled trials. I'm not aware of any randomized controlled trials that have looked at the effectiveness of acupuncture. So, I think the message would be fine to try it if you want, but no proven effectiveness.
Yeah, I would agree, nor am I aware. My view on this is that I'm a keen proponent of complementary therapy as long as it's complementary and not alternative therapy.
Yes,
when it supplants traditional methods. So if people go down the route of any treatment of unproven benefit and actually use that to eschew established established treatments, I think that's regrettable. And so I think the problem about acupuncture, if someone pursued that line of treatment at the expense of others.
Actually, can I just tell a quick story? Because I had a patient who came to clinic once who said he was taking a Chinese herbal remedy for his glaucoma, and so I examined him, and his pressure was extremely low. And I said, well, it would be great to find out what's in this remedy. So he brought it with him next time and produced this bottle of green murky liquid. We sent it off to the lab, and it actually had some very powerful pressure lowering drugs in it. So not really a herbal medicine at all.
Yes, absolutely. Tony, could you comment on drops versus surgery where pigmentary glaucoma has been the diagnosis? Thinking in terms of reading how the trabecular meshwork becomes blocked and thinking if this impacts on the efficacy of those drops that are designed to improve drainage. Perhaps you say a little bit about laser iridotomy for pigment dispersion as well.
And also SLT. So I think. Sorry. Getting an echo there. the approach to pigment dispersion syndrome is pretty much same as primary open-angle glaucoma. Phil alluded to a laser treatment which was suggested a few years ago. We know that in patients with pigment dispersion syndrome, the configuration of the iris is slightly different to the average eye, and this results in rubbing of the iris against the lens and flicking off of the little pigment granules. And there was a suggestion that if we did some laser treatment, that may change the conformation of the iris and prevent that from occurring. Now, to my knowledge, I think there was a study at Moorfields a few years ago, Ted, which suggested that actually in established pigment dispersion syndrome, there was no real value from that laser treatment. So that as an option isn't really used very often these days. So most of us take the approach of starting patients with pigment dispersion syndrome on drops, and if the drops don't work, we may consider laser. SLT is quite good, even though you have an increased risk of pressure spikes, so perhaps you'd treat them a little bit more cautiously, and then surgery if neither of those two options were successful.
Okay, thank you very much. If the PreserFlow doesn't work, can a trabeculectomy still be performed? Again, that's a very good question. I'll start a discussion about that. The answer is probably yes. Some people are advocating this device in the belief that trabeculectomy be performed afterwards, and other people are using it more like a traditional tube in the belief that it stents and provides a channel for fluid out of the eye. But it is broadly similar. Having said that, there's a dissection already made, and that might that dissection itself might cause inflammation, which might compromise the effect of trabeculectomies. But again, like there are no good studies that would answer that question. And as with all new and emerging technologies, we are looking to find the answer to that question through clinical practice, informed wherever possible by research. But sometimes the research doesn't get there in time. Winnie, what do you think?
So I suppose I think about it in two different ways. From a purely surgical point of view, we position the PreserFlow and the trabeculectomy at 12 o'clock in the eye. So you then have limited space to do your next procedure. I think if a PreserFlow failed, you're then going to use up space to do a trabeculectomy. You don't have space to put a tube in. So I'd probably go for the tube as a second procedure after that. I'm wary of putting shunts or PreserFlow or doing trabeculectomy in the nasal side of the eye, because that can cause quite a lot of discomfort for patients. So generally you've got kind of two positions and you want to think carefully how you use them. That's how I'd look at it.
Yeah. It's a very good question, one which if we asked in one of our glaucoma specialist meetings, there'd be a lot of heated debate about. So yeah, it's a very good question, really. I'm going to just, before we start wrapping up, and we've got 6 minutes left, I'm going to hand over now to Sue, who is going to just do a brief talk about an interesting and exciting development from, I believe, Dave Crabb's lab, the Glaucoma Perspective App. Sue, do you want to say something about that?
Yeah, great. Thanks, Philip. And hopefully Rishenda will be able to share her screen. As it's World Glaucoma Week this week, we have been using the opportunity to promote the Glaucoma Perspective App, which was developed by Allergan in consultation with Professor David Crabb of City University of London. And this app, for those of you that are not familiar with it, it is brilliant. It's got several parts. It's aimed at people with glaucoma in helping them understand more about their condition and the various treatment options. But the thing I really like about it is it enables you to demonstrate what the effect of various visual field defects are on your vision. And I think that's really really helpful in showing people who do not have glaucoma, but may be at risk of developing the condition, the fact that actually they can really lose a significant amount of sight loss before they've got any idea that there's anything wrong. If I see Rishenda's share her screen, thanks Rishenda, really all will be revealed. Do you want to press play? Thank you. Okay, so that's what it looks like, and then you've got David saying about the various features of the app. So there are three main parts. There's first of all describing glaucoma, and this is how we used to think that somebody with glaucoma saw their visual fields, but we now know that that's not the case. And so what the app does is, okay, that's telling you that we know that's not the case. And you will see some more screenshots from the app. So it's been funded by Allergan, so it's free. There's no in-app purchases or anything like that. So there's no excuse for not getting it. And in a minute, you will see screenshots of the videos. There we go. Okay, so that's how you launch it up on a tablet. It's available for tablets and phones. So there's the various options. So it's a way to get more information, a very sort of 21st century way of getting information about glaucoma. And you will see in a minute some videos that are embedded in the app, and you can by scribbling on either the left or the right eye, you can see the effect of that visual field defect on the actual real world. So you'll see the kettle in a minute will disappear, but not if your visual field loss is just in the right eye, because you won't notice it because your brain compensates for it. But when you start getting the same amount of field loss in the same place, in the left eye, you will see bits of the field disappearing. And that's probably about all we really need to show you on the video. And just to urge you to download it, promote it to your friends, neighbours and all the rest of it, to get them to know more about glaucoma. And we're hoping that it will highlight to people that you might think your eyesight is fine, but it isn't necessarily. Thank you.
Thank you very much, Sue. That's great. Dave Crabb is an absolute superstar, as we all know. And he's one of the people that you put two words together that would never, he's a charismatic mathematician, which aren't two words that you ever hear in the same sentence ever before. People assume he's an optometrist, but he's not. I believe his background's in statistics, but we're great fans of him. He does fabulous work. We're approaching the end. We probably have time for one or two more questions. And I'm going to go to one of our previous trustees, Sheila Page, the redoubtable Sheila Page, who asks, is a study planned of the various treatments at a distance during the last year to see which diagnoses and decisions were and were not as effective as in-person appointments? What type of mistakes were a risk? Ted, would you like to say anything about that?
When you told me it was Sheila asking the question, I thought, oh no. Again, it's a great question. Really, this sort of thing needs to be addressed through audit. So that's really looking back through the appointments and the course of clinical events over the last year. And that's something that we're looking at the moment to see whether or not patients got missed for some reason. At Moorfields, we went through all our patient records to prioritize appointments to make sure that those in greatest need got their appointments first. It didn't always work, and some people, for various reasons, either the fault of the hospital or patients being reluctant to come up to the hospital, got missed. But one of the things that we have learned is that we can be a lot more efficient in the way that we deliver care. So now a lot of patients come up to what we call our virtual clinics. So they come up for all their tests, and then we sit in the quiet of a room without the buzz of a clinic and demands dragging us this way and the other. We can assess patients in our own time and make considered opinions about the stability or not of their glaucoma and their best treatments. And then we either write to the patient or pick up the phone and talk to them about the outcome of the appointment. So there are some positive learnings, but as I say, it'll require a big effort of audit to go through and really work out what's worked better and what's worked less well.
Winnie, can I ask you, as another Moorfields consultant, another one of the great success stories, I think, of ophthalmology redesign has been the Moorfields A&E virtual A&E service. Do you want to say something about that a little bit?
Yes. So This is called Attend Anywhere. So patients, instead of coming into A&E, can do a virtual consult over a video camera. And in a lot of eye conditions, particularly around eyelids or a red eye, the doctor sitting in A&E can assess what's going on in combination with the history from the patient and the discussion about what symptoms they're having. And so that has meant that these patients can be prescribed treatment remotely, and that can be sent out to them, or they can be given advice or reassurance, or an appointment can be made for them to actually come in. So I suppose it's a form of triage, but it's treatment as well. And it's similar to what a lot of GPs have been doing during COVID, and has been very effective. And these video consultations have also been used by our oculoplastic service for follow-up of lid procedures, and again, avoiding the need for patients to come up for appointments. So that's really taken off in the last year.
Thanks, Winnie. Okay, there are a few questions left, which I'm afraid I think we're going to have to draw to a close. If people feel a burning need to answer those, we can always do that directly through the helpline, and we'll endeavour to help you with those questions.